All right, everyone. It's Dr. Lisa L. Campbell. I am back with week number 2 of our outpatient billing and reimbursement course. And this is chapter 4, which focuses on revenue management with a focus on insurance claims, denied claims, appeals, collections, and credit. So, objectives. So, number 1, notice how they always start off by saying define key terms. So, let me just reiterate something. On the day of your national exam, you're going to be expected to recall information, analyze information, apply information. Knowing the terminology can help you in those situations where you don't have a clue what the answer is, because generally speaking, there are there are 4 multiple choice answers, 2 dead wrong, and then the other 2 you're like trying to decide between the 2, and knowing terms will make a difference. So remember, knowledge, comprehension, application. All right, so define those terms, and remember, I discussed in week number 1 what concepts you needed to know for the CCS and the CCSP exam. So not all of these concepts you need to know, but you never need to know for those exams, but you never know where you're going to work and what you're going to be required to do. All right, so explain the stages of an insurance claim cycle. Describe how claim files are maintained, the appeals process, and then the credit and collections process. All right, so as a part of our revenue cycle management process, we have to maintain the files, right? Sometimes the insurance company will say, we didn't get that claim. We're like, wait a minute, according to our system, such happen, right? If there was a denial, we may need to write an appeal. And then if there is collections or credit that needs to take place, we need to write that as well. All right. So the claim cycle has 4 stages. Again, it's January 2025. Claims are not typed out on a typewriter, they're submitted electronically via electronic data interchange. And the HIPAA law actually mandated requirements for transmitting claims electronically. The next step is that the claims are processed and by the insurance company, and then they go through what is known as an adjudication process, and that's a fancy word for yes, we're gonna pay you, no, we're not gonna pay you, or maybe we will pay you, right? And then they'll give you some additional information, and then of course, if we get paid, we get the payment electronically, or we can get a paper check. Claims management is where we're basically following up on that process to make sure that everything gets completed and we get what? Paid. So the cycle of an insurance claim here is a visual, right? So um submission electronically, the computer talks to their computer, our computer talks to their computer, or our clearinghouse talks to their system. We are um they adjudicate the claim and then they pay it. So this is just a visual. All right, EDI, electronic data interchange. So I mentioned, and a lot of these things are repeated, which is good because the more you hear it, you'll remember it. So the claim is submitted quite frequently electronically. There are some manual transmission, but most frequently it is a electronic situation, right? So the claim can either go directly to the payer, it can go to a clearinghouse or a third party administrator. And so, right below that, you see some definitions like what is a clearinghouse. So basically, we send all of that stuff to them, they check it, and then they process and sends the claim out to the payers. And you probably are wondering, well, why would you do this instead of doing it yourself? Well, you got United Healthcare, Blue Cross Blue Shield, Aetna, Cigna, right? So you send all of that to the clearinghouse, and then the clearinghouse sends it to where it needs to go in the proper format, because insurance companies also have rules that have to be followed, and the clearinghouse helps us not have to worry about that because that's their job. Then you have a TPA, or a third party administrator, that can also do the same thing, but from a different perspective. Then you have an EOB, or a remittance advice. Very important to distinguish between the two. The EOB, or the explanation of benefits, that's the paper that we get in the mail as the patient. Remittance advice, think of that like a check stub. That's sent to the um, healthcare organization to tell us how they paid our claim, how they adjudicated our claim. So EOB goes to the patient, RA, or remittance advice, goes to the hospital or the medical group. A claim is said to be clean when it meets all the requirements. Now, you know how you have a washing machine? And you know how the washing machine scrubs your clothes and then spins them and then it cleans them? Well, a lot of organizations have what's known as a claims scrubber, and the claims scrubber is designed to help us submit a clean claim. So here is an example of, that pink and white claim form that you saw. It's in the textbook. Well, the insurance company, they don't get that pink and white form. That's just, what it looks like in a paper format. But basically, what happens is, to get the flat file, the system converts that claim form to what you're seeing right here, puts it into computer language. All right, so EDI, or electronic data interchange, that's the computer to computer transfer of data, right? I already told you that HIPAA mandates that certain data elements and format be in place. That is for consistency. Now, everyone that is considered a covered entity is required to follow HIPAA standards. Um, One type of claim that I can think of that may not align with HIPAA is like a workers' compensation claim. I don't think they have to follow um, the HIPAA standards, only organizations that are known as covered entities. Now, something I will tell you, covered entity is a concept that you need to know for the CCSP exam. So, covered entities process electronic claims and are required to use HIPAA standards. And here's a list. The book gives us this list of covered entities. All right, claim attachments. So sometimes the insurance company wants us to attach files to the claim. Generally speaking, they will tell us what they want us to attach. Sometimes it's nothing, and they say, we'll contact you if we need something. So, for example, in your CPT class, we talked about unlisted codes and a special report. So if we use an unlisted code that doesn't have a reimbursement dollar amount attached to it, we have to send them the documentation to show them what we did, and then they make a decision as to how they're going to process the claim. Okay. Sometimes maybe we put a modifier 22 on a CPT code saying that the service was um, it was longer, right? And so they may say, well, let me see that documentation to prove um, or validate, I should say, what you said you did before we pay you. All right. So, how to avoid resubmitting claims. And this really, I will tell you that this book, compared to the book that we had last semester we had the book from AHIMA. This book is presented in a different way, which I think is great because you get to see the concepts, explain different ways, which helps it stick. So, how to avoid resubmitting claims. So, delayed claims are it's missing some information, right? So remember how I said we have to verify insurance coverage with the insurance company? So what we have on the claim from the perspective of the patient's information should be the same thing that they have in their system. And if we make a mistake and put something wrong in our system, that could cause a delay and require us to correct and resubmit. But remember, every 2 weeks, the organization has to pay us. So it is in our best interest to ensure that we are capturing accurate information at the time of service. Then there's another concept called coordination of benefits, or COB. This is when the patient has more than one insurance, and it really governs who the claim should go to first. So let's say the patient has Medicare and Medicaid, which we're going to talk about more in the coming weeks. And let's say the claim is supposed to go to Medicare first. A lot of systems may have coordinating efforts where the claim can cross over to the next payer. So, like after they pay, then they'll send it over to the second payer. Not every insurance company has that. And so you send it to the primary payer first. After they pay, then you send the claim to the secondary payer, and then they will pay. Please keep in mind that they're not each paying 100% of the claim. The payment is never more than 100%. All right, so the claims processing process. So the claim is submitted, right? They're sorted to collect and verify the data about the patient and the person who provided the services. I talked about, the claim scrubber, right? So they have systems in place that is looking at the information, validating it. It can edit it, and after it goes through that process, they begin to adjudicate it. And today it's a computer that's doing a lot of this work. All right. So here, the bottom, you see that pink and white form? That's the claim form, right? And that's in the paper format. And they show it to you in the paper format in an organized format instead of the flat screen, just so you can get a visual of what it looks like, right? And then the top is perhaps what you'll see the claims examiner will see, right? And so what the computer is doing is basically comparing data. So you see insurance ID 1, 2, 3, 4, 5, 6, 7, 8, 9 in the blue part, and then in the pink part in block 1A on the right it says 1, 2, 3, 4, 5, 6, 7, 8, 9. So the system is comparing if the information is the same. And if it's not, that can be a reason for them to deny the claim, which is why accuracy from the beginning of our revenue cycle process is important. So, adjudication is comparing the claim to payer edits. Remember, I talked about on the CCS and the CCSP exam, you needed to know about the National Correct Coding Initiative. So, that's one of the edits that the system could be looking at, right? So, they are verifying all of these things that are represented by the bullet. The claim is not a duplicate. The information is available so that they can process the claim. They're looking for that we follow the rules. So in our organization, we have conversations all the times about what rules we need to follow for a certain payer, right? They're also looking at, is it a non-covered benefit? Is it an unauthorized service, right? So all of these things happens during the adjudication process. And this is how they come up with, I'm making it simple. Yes, no, maybe. Yes, we are paying you. No, we're not going to pay you. And then maybe, but we need to see XYZ. All right. So here is a visual of the claims adjudication process and payment. And they give you these visuals in the book because sometimes reading it doesn't stick, but when you see a diagram you're like, oh, okay, this is step one that flows into step two, that flows into step three. Voila, we get paid or we don't get paid, and now we got to find, maybe do an appeal. All right, so after we get paid or after the claim has been finalized and they say yes or no, we, as the healthcare organization, what do we receive? RA, remittance advice. Now, it's 2025. Remittance advice is a term for a paper version, like your paper check stub. And so today you're seeing that we get an ERA, electronic remittance advice. And then, of course, the EOB goes to the patient. Medicare actually has another name for the EOB, and I think they call it notification of benefits or something. I forgot the name. When we get to the Medicare chapter, we'll see it. But they have a different name for it. But it's essentially the paper you get in the mail. So if you have insurance coverage, Blue Cross Blue Shield, Aetna, etc. Next time, look at yours, to evaluate, is it correct? Because sometimes we as the healthcare systems make mistakes on those, and patients catch it and call the insurance company and say they committed fraud. So, all right. So, state laws do require that we get paid promptly, but it's not necessarily, 1 to 2 weeks. Here is an example. Sometimes it can be, a lot of times it is. It just depends on the payer and, if we're missing something, etc. So here is a sample remittance advice. And what you're seeing on this RA is typically the payer will group together multiple patients. So on this particular one, this is for Jane Sanders, and you can kind of see diagnoses codes. You can see some HICPICS codes, so acne and asthma, but they generally put the numbers and not the words. All right, here's an example of what we get in the mail, EOB. And I'm probably a nerd, but I'm always looking at my EOB to see if there are codes because as the patient who knows the rules, I'm always looking at, okay, how did they build that service? They said it was level three. Oh, yeah, that was level three, right? I'm always thinking through um, the rules and how it apply in my case. So this is what we get, and then the remittance advice is what the insurance company gets. So we have to keep copies of all of our billing documents. A lot of places say 6, 7 years. CMS requires 6 years. State law may vary. Oh, something I want to tell you. On the CCSP and CCS exam, they only follow federal rules. They cannot possibly give you a test with rules that apply to your state because CCS and CCSP are national exams. Okay. So we have to maintain the files for the work that we've done, and that includes the medical record, right? Because they can come back 5 years from now and say, hey, we paid you for this claim for this patient on this date of service. We want to see the medical record. You don't have the medical record, you can't prove that you provided the service. All right, unpaid claims. So we do maintain electronic copy of every claim that we submitted, right? And when we are posting the payments to the patient's account with the RA remittance advice, we're making sure that we were paid correctly. If the claim was denied, they generally give us some denial codes, and they'll tell us like non-covered service, errors, like whatever the case may be. And if it's something that we can correct, we should correct it. They're banking on we don't resubmit it. then they get to keep the money. But if they denied it and we truly deserve the money, we refile that claim. Remember, hospital has to pay us. So we want to make sure the hospital gets paid. All right. So denied claims and the appeals process, there are different types of denials. So the administrative denial, it can be missing data. Then we also have clinical denials because maybe the service was not deemed medically necessary. Remember, CPT shows what happened, the diagnosis shows why, that supports the medical necessity. So very important that you are not so robotic in the work that you do and that you're able to spot these things and we handle them in house before the claims hit the insurance company. So part of our process involves identifying that there's an error, managing, resolving that error, monitoring to see, okay, we corrected the error, resubmitted the claim. Okay, so now we're waiting on that payment to come through, right? And then this process would not work if we don't educate our staff, whether that's us doing the work, the providers who are documenting. Education is key. And then the appeal is where we explain why a claim should be paid. And then they respond to us with, they pay it or they don't. So, reasons for denied claims. Here's a whole laundry list. One of them you should see immediately is termination of coverage. Remember, when you get insurance, they give you a card. When you no longer have that insurance, they don't send you another card that says, I no longer have this insurance. So it is important that we are verifying the patient's insurance each and every visit to make a determination of if that coverage is no longer in existence, how will the patient pay for that visit? We have to ask patients these questions when they're face to face. I already explained. You try to do it on the back end. Now you're wasting time, energy, and effort, right? Who wants to send out an envelope, paper, and a stamp to collect $5 that we could have collected up front? Why would you spend $5 to collect $5, right? It does not make sense. They zero each other out. All right, so this is a list of reasons why claims are denied and appeals process. So this is something I would say on the CCSP that you may need to know about the levels of appeal. Here in the book, they talk in this chapter about the Medicare appeals process, and you see there's different levels. So first is by the Medicare administrative contractor. That's actually the agency that receives our claims. And then if we don't get anywhere with them, we do a second level. We have a qualified independent contractor. We don't get anywhere with them. Level 3. There are also, and this is a very simplified depiction of the appeals process. It's a little bit more complex than this because each level there is a minimum of dollar amount that you can appeal. But you should at least understand that there is an appeals process, and this is what it looks like. This is what it looks like for Medicare. Is going to look different but similar with other payers. All right, credit and collection. So this is where we know we provided the service, so we need to collect the copay at the time of service. Again, our contracts say that we will make an attempt to collect the payment, right? If the patient doesn't have it, they don't have it. But if they have it, we need to get it. And that is just really about being consistent in our process of asking the patients for the money. Remember, if we bring money into the facility every day, whether it's copays that we're collecting at the time of service or claims that we sent out 2 weeks ago and now we're getting paid for those, we need that revenue back into the insurance company or back into the um, organization so we can pay our bills. All right. So, as it relates to credit and collection processes, they have to be consistent. There are, excuse me, there are rules we can't call patients at 10 o'clock at night or at 7 o'clock in the morning. And there are federal laws regarding if we're going to do payment plans with patients. And so there's a list here that you can review. Collections, excuse me, collections. One of the things you'll hear as a term that is used is how old is the account? What is the age of the account? 30, 60, 90, 120 days. Um, it is important that we bill patients when we get that remittance advice. Why? When we're getting the remittance advice, what is the patient getting? The explanation of benefits. They know they owe the money if they open it up. But this is the reality. When you are struggling to navigate life, as most of us are, a doctor bill is like the last thing that you want to pay. And so a lot of times it's a bill that gets overlooked. So it is very important that we have consistent processes. And usually what happens is we're working those accounts to we're working those accounts to try to get that money in. All right. So this is an example of an aging report. If you look on the right in the yellow, you see how it shows that the patient currently owes $160, and it is something that we're waiting for from their insurance company. And so the insurance company currently owes us $160. The older the account becomes, the challenge becomes with getting that money. A lot of organizations will outsource their older account. So instead of us as the healthcare organization trying to collect the money, they'll sell the account to a collection agency, and then the collection agency is contacting us. And when they buy our accounts, they are on a mission to get their money. And so what'll happen is you'll see where they are offering us deals to make that payment so that they can close out that account. All right. Now you see why I break these up into 30 minutes because there's a lot to go over. And so now we talked about revenue management from the perspective of insurance claims, denied claims, appeals, credit, and collection. We also talked about those different stages of the insurance claim cycle. We talked about the importance of maintaining those files. Medicare requires 6 years. Some state statutes may require longer. You got to be able to prove that that service was provided, right? Then we looked at the appeals process and the role of credit and collection in processing claims. This is the end of our week 2 lecture for our outpatient billing um, and reimbursement course. So this is chapter 4. We're typically doing 2 chapters a week. So I'll see you next week. Thank you.